Hi everyone and welcome back to Dr. Happy Vagina. This is an educational channel about women's health and my name is Ida Bergman and I work as a gynecologist and obstetrician in Sweden. And today we will speak about cystocele and about the surgical treatment which is called anterior colporrhaphy, a very complicated word. So in this video I will talk you through what is a cystocele, what kind of symptoms can the cystocele give, what are the treatment options, and we will speak specifically about surgical treatment. And I want to tell you what you can expect in terms of results, but also in terms of risks. Okay, so a cystocele, we will start by, I will draw a little sketch about the anatomy, the normal anatomy. Here we have the urinary bladder. Here we have the vaginal opening. We have what we call the anterior vaginal wall, which is just below the urinary bladder. We have the posterior vaginal wall, and we have the anus here and the bowel, which goes behind the posterior vaginal wall. So the anterior vaginal wall, if you take your finger and you insert your finger in your vagina and you push up against the belly, this is where your anterior vaginal wall is. And if you turn your finger and you push more against your rectum, this is where your posterior vaginal wall is. And in the top of vagina, we have the cervix and we have the uterus. And between the anterior vaginal wall, I will write here a little arrow here. This is the anterior vaginal wall. Between the vaginal mucosa and the bladder, we have something called the pubocervical fascia. And this is a strong structure that gives the support to the anterior vaginal wall and thus the bladder. So it's a connective tissue barrier that helps to keep the vagina in place. We have the same kind of structure in the backside called the rectovaginal fascia, but in the front side it's the pubocervical fascia. And if this pubocervical fascia loses its support, gets damaged, for example from vaginal birth or from coughing, chronic coughing, or obesity where you have a lot of pressure on this anterior wall, or if you have chronic constipation and you sit and strain, you apply a lot of stress on this anterior vaginal wall, this wall might lose its support and you will get a prolapse of this anterior vaginal wall. And why do we call it cystocele? Yes, it's because we have this bladder here and it will follow this anterior vaginal wall when it prolapses. So I will try to draw an image of a prolapse. We have the urinary bladder coming down like that. And here we have the anus and we have the vaginal orifice like that. And the bladder protrudes outside of the vagina. Here we have the back wall, we have the uterus, cervix here, and here we have the anterior vaginal wall coming down like a bulge, coming out of the vaginal orifice. So the bladder normally should stay like that, and when you have a prolapse, it comes down and outside of the vaginal orifice. Okay, so now we will speak about the symptoms that what this can then cause. And the most common symptom is that you feel or you sense or you can see a bulge coming out of the vagina, a bulging sensation. And if you feel with your fingers, it's usually a soft bulge that comes out. It's not the hard tumorous bulge, it's a soft bulge. And also when you see that the bladder is affected, you can understand that also you can get symptoms from your bladder. And one of the common symptoms is because the bladder and the urethra gets a little kink. This might cause bladder emptying difficulties, because the bladder should be straight, the urethra like that, and when the bladder comes out, it kinks the urethra, so there is more resistance. So maybe when you go to the toilet, the urinary stream is weak. Maybe you have to modify your position or take your fingers and push in the anterior vaginal wall to help the urine to pass. Many women describe that in the morning, when they have lied down during the night, they go to the toilet, it's more easy. But during the day, when you are up, the gravity makes the prolapse come more and more out, and the kink becomes more and more advanced. Then in the evening or in the night, it's very difficult to void. Okay, and sometimes the urinary bladder gets a little bit irritated from this stretching, and you can experience like overactive bladder symptoms, that you have to go often to the toilet and you get these cramps in your urinary bladder. But it's very important to know that often prolapse and normal diseases of the bladder can coexist, and they usually come in this premenopausal, postmenopausal age between 50 or 60. This is the peak incidence in women for both prolapse and overactive bladder symptoms and incontinence. And you can have both of these problems in the same time. So this is why we cannot promise that surgery will help your urinary bladder symptoms, because there can be another reason for these urinary symptoms. So if you do surgery and the surgery is successful, we can almost promise that this bulging sensation will disappear, and you will have a more, we will get away this kink underneath the urethra, which makes the bladder emptying difficulties usually go away. But how the urinary bladder, other urinary bladder symptoms will react, we really don't know. Okay, and we will speak a little bit more about this when we speak about the surgical treatment and what you can expect. All right, and now we will speak about treatment. And many of my patients, they ask, can I do Kegels exercises, train my pelvic floor to heal my prolapse? And the quick answer is usually no. It's very important to maintain a good muscular function in the pelvic floor, and sometimes you can avoid the prolapse to become worse, or you can little reduce the symptoms, but in most cases it's very difficult to exercise away an already big existing prolapse. If you have mild symptoms, mild prolapse, yes, this can help. But if you have a big prolapse coming out, then usually pelvic floor exercises will not cure this. It will definitely not harm anything, and it will be beneficial. But usually, if you have a big prolapse, we don't send our patients to the physiotherapist for this problem. But if you are not ready for surgery, if maybe you don't want to do surgery, or you are too sick to undergo surgery, or maybe you want to have more children and you are not ready for surgery, we can treat you with a prolapse ring or a pessary. So this is the non-surgical treatment, and this means that there are different kind of rings. But for example, one ring can look like that, or it can have a little membrane. And a doctor or a midwife will test the appropriate ring, the size and the module. And we press this plastic ring, we insert that in the vagina, and it opens. And it should keep the prolapse in place, like that. So we have the urinary bladder here. So we put the ring inside the vagina to push up the prolapse and keep the prolapse in place. And normally you take out this ring after 3 months to check that the ring hasn't been too big, and so it's not pushing the vagina and giving you wounds in the vagina. So you have to check that it's a good size. And some women, they manage after to by themselves take out and insert the ring, and some women come to the clinic regularly, maybe every 3 to 6 to 12 months. You come to the clinic and change their ring. Okay, and very important to know, if you are postmenopausal, you will have low estrogen levels in your body. This makes this vaginal mucosa thin, and if you put a ring, there is a big risk that you will have this kind of wounds in the mucosa if you don't use local estrogens. So local estrogen therapy is mandatory to use when you have the ring if you are postmenopausal. It's very, very important. But otherwise, except for these wounds, there is no risk with ring treatment. And then the most popular treatment is surgical treatment. Surgery. And this surgery is called anterior, because we work in the anterior vaginal wall, and it's called colporrhaphy. So colpo is the Latin word for vagina, and raphy means that we push something together. So anterior colporrhaphy is usually a day surgery treatment. So you come to the clinic in the morning, fasting, you will get sedation. It means you're not fully anesthetized usually in most of the clinics nowadays. You get a little sedation where you will sleep, and then the doctor applies local anesthesia in this area. And the procedure takes about between 15 to 30 minutes. And after, you will wake up and eat, and you can normally go home after 2 or 3 hours. And the surgery itself, it means that the doctor will go inside your vagina and will open this vaginal mucosa, so the first layer in the vagina, and will find this pubocervical fascia that I was speaking about. On the sides, we take the healthy fascia on the sides of the vagina, and we push that together in the midline with stitches. These stitches will resolve by themselves. So we go into this area. I will draw this again. We have the bladder, we have the vagina, we have the anterior vaginal wall, and we will open this vaginal mucosa. We will try to find your pubocervical fascia, and we will push that together in the midline with stitches like that. And these stitches will dissolve by themselves. And we want your healthy connective tissue to scar together so that you will get a new support under the bladder. And different kind of women have different kind of scarring tissue. So some women get strong, stable scars. Other women get more loose, thin scars. And this is why there is a risk for some women that the prolapse will come back. So this will fail, and you will get your symptoms back. And usually we say that 70%, so 7 of 10 women will be cured, but 30% will get the prolapse, will get a relapse. And if you get a relapse, there is another option, and this means that instead of using your own native tissue, we will put inside a plastic mesh. This mesh means that we give you an artificial support of the connective tissue. So this mesh will be permanent and will stick to your body for the rest of your life. And this mesh procedure gives an increased chance of getting cured. So about 90% gets rid of their prolapse. However, this mesh, some women get problems with this mesh, so it comes with a little increased risk of complications. You can get mesh exposure or different kind of symptoms, and it's a little bit sometimes tricky to treat these mesh complications. So this is why we always opt for this native tissue anterior colporrhaphy as a first line treatment. And if you get a failure, we can do the plan B and use the mesh. So we use a mesh for recurrences. Okay, so you can expect 70% chance of being cured, and I really hope you are one of these 70%. And now we will also speak about the risks. We will speak some about the urinary symptoms, because like I told you, many women have urinary symptoms also accompanied with the prolapse symptoms. And when we look at studies, we can see that approximately 1/3 will get better. So if you have overactive bladder symptoms or incontinence symptoms, you can have a 30% chance of getting better after your prolapse repair. 1/3 will have no change. So the urinary symptoms will be like before. And we have 1/3 that can get even little worse because when we do surgery near the bladder, we affect the nerves that go to the bladder. So sometimes the overactive bladder symptoms can be even little worse. And now, very, very important to know, 10% of women will get urinary incontinence that they didn't have before. So you were completely dry, you did your prolapse procedure, this bulge goes up and everything gets better, but you start to leak urine on straining when you cough or laugh or when you move. So you get de novo stress urinary incontinence. And why is that? I will draw you another picture to explain this. Okay, so if this is the situation, we have a prolapse of the bladder, but also many women have a weakness, a weak tissue also under the urethra. You see this little part here is the urethra, and we never do surgery in this area under the urethra when we do prolapse procedures, because this can cause more harm than benefit. But there might be a case that the tissues around the urethra is weak, and also the tissues under the bladder is weak. Then we do a prolapse procedure. We still have, because we haven't touched the suburethral area, we still have the weakness under the urethra, but the bladder is now in place. We don't have this kink anymore stopping the urine. So now the kink is gone, the bladder is in place, but we still have the weakness under the urethra. And this will cause, when you cough or strain or laugh or jump, this will cause urinary leakage. And this is why 10% of women with prolapse, they have problems with urinary incontinence, but the prolapse will mask this, and when we reduce the prolapse, you will get urinary incontinence. And it's important that you have this in your mind, that you know that this might happen. And if you are affected by this, we might have to do an incontinence procedure as a step 2 procedure. We don't do it routinely. We see what happens, we follow up the women, and we do a secondary procedure if necessary. And there is a video in Dr. Happy Vagina about advice on recovery after a pelvic floor surgery. So I advise you, if you will undergo surgery, that you will look at this video. I give you advice on how to optimize your healing after your anterior colporrhaphy. All right, so this was all for today. I hope you learned something new and that you are a little more prepared for your upcoming surgery.